Our next speaker, I would like to invite Dr. Pınar Borman. Dr. Borman is a professor of physical medicine and rehabilitation and algology in the University of Ankara Medipol in the Department of Physical Medicine and Rehabilitation. Over to you, ma'am.
Can you see my screen?
Yes, Pınar.
Yes, ma'am, it's visible.
Okay.
It's perfectly fine.
Okay, thank you for the nice introduction, and thank you for your kind invitation, especially to Dr. Das and Arun Reka and all organizing committee. My topic is the role of manual lymphatic drainage in breast cancer related lymphedema. Breast cancer is the most common cancer among women globally and the leading cause of cancer death among women worldwide. But it can also be seen in males, as you have seen at the following picture. With advancements in breast cancer diagnosis and treatment, survival rates have significantly improved and long-term complications like lymphedema have become increasingly prevalent. Lymphedema is a significant and worrisome complication that can arise following breast cancer surgery, lymph node removal, and/or radiation therapy. According to data from various countries, a substantial percentage of breast cancer survivors, up to 70%, are reported to develop breast cancer-related lymphedema, which leads to swelling, discomfort, mobility issues, and emotional distress. Despite its impact, healthcare professionals continue to overlook the importance of awareness and regular monitoring of this condition. It is still a major healthcare problem in both developed and non-developed countries, and it is associated with a substantial increase in healthcare costs. Previous studies indicated that the prevention of lymphedema would be cost-effective, and the costs related to treat lymphedema increases if the compliance to maintenance treatment is not fully provided. Therefore, not only the prevention but also early diagnosis, treatment, and maintenance are very important. There is no cure, but lymphedema is a treatable and manageable condition. Extensive multidisciplinary management is needed, and the team should comprise the physicians, physiotherapists, nurses, dietitians, psychologists, with the patient and the family in the center. There are also medical therapies for especially the complications of lymphedema. We commonly use physical therapy modalities like laser or kinesiotaping, and of course psychosocial approaches should also be taken into consideration. But complete decongestive therapy is the main treatment for breast cancer-related lymphedema. It has two phases, as you have seen here, active treatment and lifelong maintenance phases. Both of these phases comprise education, skincare, and exercises. But in active treatment, manual lymphatic drainage and compression bandages are used. And in phase 2, in the lifelong maintenance period, self-MLD and compression garments are provided for patients. Manual lymphatic drainage is the cornerstone of effective lymphedema therapy, but as seen in some of the studies, in isolation, it may not render sufficient results. Therefore, it should be used with combination with additional modalities like compression and/or skincare and exercises. It is first invented by Emil Wader, but later Foldy has progressed this method and it has become the main part of complete decongestive therapy. It is a manual manipulation, soft tissue mobilization technique which is directed at either the superficial or the deep lymph vessels and nodes. A typical treatment involves both aspects to truly and logically decongest the system, consistent with our current anatomical and physiological understanding of healthy function, which has been mentioned by Dr. Shuba before. MLD increases uptake and transport macromolecular waste, lymphatic loads from areas of interstitium, and we all know that compression alone may not stimulate the lymphatic system. Therefore, the spatial techniques used in MLD effectively increase the intertissue fluid uptake into lymph capillary network. This filling force, along with the stretch stimulus of skin traction, raises intravascular pressure and peristaltism of lymph collectors, trunks, and ultimately the lymphatic fluid empties into the blood circulation. We can summarize the effects of MLD as you have seen here. It increases the lymph production, lymphangioactivity, it provides relaxation and soothes discomfort. It has also analgesic effects by gate control theory, and it provides a diuretic effect for the patients. MLD is not only used for lymphedema, but it is commonly used for phlebolymphocytic edema, post-surgical post-traumatic edema, lipolymphedema, or complex regional pain syndromes. And we can also use this method for systemic disease causing edema like rheumatoid arthritis, scleroderma, or cyclic idiopathic edemas. There are some contraindications for MLD, as we have seen here. If the patient has unstable congestive heart failure or renal failure, or if she has acute infection or acute deep vein thrombosis, we should not apply MLD. There are also some contraindications for neck area like hyperthyroidism, hypersensitive carotid sinus, cardiac arrhythmia. And we have also some relative contraindications like malign lymphedema, or we commonly do not prefer to apply it during radiation therapy or chemotherapy, as the patients have a sensitive skin after radiation therapy and they have infection risk during the chemotherapy. For abdominal MLD, if the patient has pregnancy, or if she is in menstruation period, if there is diverculitis, intra-abdominal scars, unexplained pain, or recent abdominal surgery, we do not prefer to apply MLD for these patients. When we look to the literature, there are limited studies for the effects of sole MLD. The majority of the studies combine and investigate the effects of combined MLD and other CDT techniques. But we can say that MLD is a safe and well-tolerated technique and adds additional benefit to compression bandaging for swelling reduction. When we compare to individuals with moderate to severe breast cancer-related lymphedema, we can say that the patients with mild to moderate breast cancer-related lymphedema may be the ones who benefit from adding MLD to an intensive course of treatment with compression bandaging. For symptoms such as pain and heaviness, up to 80% of the participants reported feeling better regardless of which treatment they received, but the reduction in volume and increase in quality of life is reported as limited in these studies. In previous studies, we can also see that MLD does not affect the recurrence or dissemination or cause the metastasis of the cancer. There are some general principles for MLD. It should be done in a gentle and careful method. The application must be strong enough to avoid gliding over the skin, but instead stretching the skin gently in desired drainage direction. The techniques should not cause hyperemia. The duration should be at least 45 minutes for one extremity, and after MLD, urine output increases. MLD is performed by 4 main strokes. There are pressure working phases and relaxation resting phases. Stroke application should be at a rate of about 1 time per second, with 5 to 7 repetitions per area. And the direction of stroke should be towards to the normal drainage areas. We first decongest the central areas, and the treatment of extremities starts proximally and progresses towards the distal regions. Then the stretching direction should be from distal to proximal. Here you can see the strokes. We commonly use the stationary circles. For the extremities, we use pump and scoop. And for the trunk areas, we commonly use the rotary stroke techniques. Here you can see the direction of drainage in a left arm lymphedema. In a patient with left arm lymphedema, you can see the drainage ways. And here you can see the order of sequences. First, we begin from the central areas, from the neck, abdominal area, and then we decongest the contralaterally axillary nodes. And then we open the anterior axilloaxillary anastomosis. And then we use the ipsilateral axillary inguinal anastomosis areas by stroke methods. And we have to apply these techniques also for the posterior axilloaxillary anastomosis. After these central areas and anastomosis, we begin from the upper part of the arm, the cubital area, and then we come to the lower arm and hands. And we finish the MLD with repetitions of strokes in the abdomen and neck areas. If the patient has bilateral lymphedema because of the bilateral breast cancer, we do not use or decongest the axilloaxillary anastomosis. We drainage the neck and abdomen area, and then we drainage the bilateral inguinal nodes. After this, we use the anastomosis of axilloinguinal anastomosis bilaterally, and then we apply the MLD from beginning to shoulder, upper arm, elbow, lower arm, and hands order. And again, we terminate the MLD with abdomen, drainage of abdomen and neck areas. Self-MLD is also an important part of prevention and long-term care, and it should be done at least 3 times a week. Preferably, we educate the patients to apply this technique to themselves every day. We should educate the patient or spouses in the intensive phase of the CDT, and we have to spend time with patients to the families. We teach them the main principles in an abbreviated method, which takes generally 20 minutes with gentle and slow movements. Like we tell them that the strokes should be like caressing of the baby's hand. And we also lead them to our Turkish Society of Lymphedema and Lipedema website. We use visual materials and brochures, and we can also let them to take videos during the intensive phase and during our teaching methods of self-MLD to them. I thank you for your attention, and I would like to invite you to the 13th ISL World Congress of Lymphology, which will take place in Turkey, in Antalya, between 15 to 19 October 2025. Hoping to be together with all of you there. Thank you again.